Three, two, one, broadcast is live. All right. Good morning, Dr. Rosensweet. Welcome, women.
Good morning, Carolyn. Good morning, everybody.
Good morning,
Anyone
everyone.
who's here, we welcome you.
Indeed, we do. It's a sing-along Q A. So, we are Tuesdays and Thursdays, 7 a.m. Pacific Standard Time and 10 a.m. Eastern Standard Time. Dr. Rosensweet and I are going to do a good, 25, 30 minutes of my asking questions that you guys have sent. Good morning, Elaine. Good morning. Women will be coming up. So we'll do this first. I'm going to ask the questions, and then you guys can go ahead and ask the questions, and our dear Dr. Rosensweet is going to answer them for you. So here we go. This is my question, because I'm doing this. I get to start off with my own question first. All right, Dr. Rosensweet, you've got to be ready for this one, because I've asked it of you before. All right, women are suffering from menopause. All right, we're given hormones. We think they're going to work pretty quickly. They don't. Some women are really lucky. They do. But for most of us, they don't. So what I want to ask of you is, while we're waiting for these hormones to work, which do work, I know they do because I'm living proof of it, what would you recommend in terms of like what we can do for rapid relief in the meantime?
You know, Carolyn, oddly enough, 25 years, this is the first time I've heard that question. Can you believe that?
That happens.
Yeah. And I would like to back up a little bit because it's a wonderful topic. And, you know, some women, they go receive some treatment. It works in a day or two or three. They feel better. And it's like a miracle, and they love it. And, you know, and then tweak it a little bit, and we go on for years and years and years. And that happens, but it's not common. And more commonly, I'd say 2/3 to 3/4 of all the women that I've ever consulted with, or all the physicians and nurse practitioners that I mentor and teach, all of their patients, it's far more common for it to take time. And it makes sense because at the age of 20, a woman's hormonal output is at its absolute maximum from her ovaries. And then from the age 20, gradually there's a decline occurring. And so by the time you're in your 30s, 40s, and the period stops, there's been years and years of that decline. And for every decline, our bodies are so exquisitely designed that there's an adjustment internally. And so decades of adjustment, and we can't really expect. Hello, Kim Hicklin, David. My goodness gracious. Welcome to you.
NESP summer.
We can't necessarily expect that we start giving hormones and there's going to be a total, complete, rapid adjustment back to normal. No, we're patient. That might be why doctors and patients are named patient. Patients are patients, and doctors are called to be patient. But at any rate, should it occur that a woman doesn't acquire treatment until after a period has stopped, and maybe there's a delay in there, maybe there's a week, or not, that's not such a big deal, but a month, that's not such a big deal, but a year or two or three before a woman finally gets inspired to get good treatment, well, what happens in that very low hormone environment? Because once that period stops, that's the signal that the estrogen has collapsed pretty much. And so is the progesterone, and usually the testosterone is collapsing or has collapsed by then as well. During that interim, when those hormones are super low, as announced by no period, the receptor sites that the hormones act upon, they go to sleep, so to speak. They go dormant. So when a woman intercepts treatment and starts restoring hormones, we want to go cautiously. We don't want to flood those receptor sites too fast. As we supply the hormones, the receptor sites will awaken. And that's a variable timeline, woman to woman, among the many variations of individuality, woman to woman.
Well, so, you know, I'm sorry to interrupt you, and I want to say good morning to Elaine and to Tabitha and Kim and Elizabeth and Elaine on top. Welcome. I know when I first spoke with you, I had a major meltdown one day. I mean, I just went to the moon and couldn't come back. And I was just stupefied because I was scared. I think maybe some of it, a lot of it, not some of it, has to do with the trust in your own doctor, because to feel safe and to know that it is feasible to feel better helps to control that anxiety. I know that there's a physiological reason for the anxiety, aka adrenaline rushes and so on. When we understand that and know that we're not going crazy, there's some relief. But there really isn't, you know, it'll bring me into other questions that I have, and I have questions here, but you know, it's really scary for a woman who's in menopause, who's feeling like she's losing her mind, like I'm forgetting her name. How can I forget her name that walked into your office?
The very first patient I ever encountered
Deborah,
25 years ago,
yeah.
Deborah, who was going
And,
crazy.
right,
Well,
and we do.
Well, she was in the perimenopause. Her periods hadn't stopped. It was her progesterone that had tanked. And
Right.
just restoring progesterone that early had a very dramatic effect. It worked within days.
Right.
And, you know, if things are super serious, I mean, to the point where anxiety or depression gets very severe, I'm always open to what works. And sometimes medications are needed. You know, and for that, you really want to seek the prescription from someone who really knows their antidepressants, who really knows their calming drugs. And yeah, I mean, I haven't seen women have to resort to that, but that doesn't mean that it wouldn't be a good tool for a woman who is really in duress. And usually it's temporary, because these hormones are so powerful, and they're so powerful around mood. You lose those hormones, you lose mood. A lot of women lose mood majorly. That as the hormones restore, oh, I've seen this, where a woman, oh, she forgot to take her Xanax that morning. Or, oh, she's not taking her SSRI because she just forgot it. It's not an accident that she forgot it. She was feeling better. The hormones were starting to work. And in a proper way, gradual titrating down of dosages, that time can come. And, you know, if you start to titrate down an antidepressant, for example, and you start getting really depressed, you bring it back in. It's not like
Right.
these are written in stone.
Yeah.
It's a dance. It's a delicate dance. And someone who really knows how to guide the process can really guide the process for the individual woman, which is, you know, the woman having access during these delicate initial periods really matters. It's one of the things about our method is we provide that access. We know
Well, I can guarantee you, I do not forget to put my hormones on in the morning, and I do not forget to put them on at night. That is just not happening. I would fly all the way back home to get them if I had to. So, okay, I think you've answered that question. I see. I want to welcome Jill too, and we'll get to your questions in a minute, you guys. I promise you, we will. I think maybe Elizabeth asked this. I'm not sure. I have another one for you, Dr. R. Dr. Blooming, who you know, and who I know, who wrote in Estrogen Matters, feels that progesterone is not necessary for a woman who does not have a uterus, but you do. Many doctors that women are talking to seem to feel that a woman who has had a hysterectomy, does not have a uterus, feel that progesterone is not necessary. However, there are many doctors that do. So we're at a crossroads. What do you think?
What an excellent question.
I can't take credit for it.
There's so many. There's I have a very strong opinion on a lot of matters, and I say every woman needs progesterone, uterus, not uterus. There are exceptions. There's the rare woman who does not tolerate progesterone for reasons we could get into sometime, but that's rare. But uterus or no uterus, we always treat women with progesterone. I understand why traditional doctors have originated that belief that if you don't have a uterus, what do you need progesterone for? Because one of progesterone's primary functions in a menstruating woman is to balance that estrogen so the endometrial lining doesn't get too thick. And in a menopausal woman, that estrogen, that progesterone is very important in a woman who has a uterus to balance the estrogen so the endometrial lining doesn't get too thick and she starts to menstruate again. Yes, that's a very important function. However, progesterone, like any hormone you can name, these biochemicals are so strong and they have universal effects throughout our body. For example, progesterone has profound effects on the brain and the mood. And progesterone is even used in brain injury. It's that effective, men and women. But that's not its principal effect. I mean, it has a tremendous calming effect, and you can't name many hormones that do that. Progesterone is the only biochemical that I know of that stimulates osteoblasts to lay down new bone. Holy mackerel. Do we want to protect the bones and keep laying down new bone in bone metabolism, which is ongoing? Absolutely. So for those two reasons alone, for the progesterone's effect on mood. Now, progesterone has other effects, but I want to be very clear on my very strong opinion about this, that almost every single woman should be on progesterone, and sometimes as early as your 30s, because that's when progesterone can start to decline, but certainly in menopause and for the rest of your life. Exception, for some mysterious reasons that I have not sorted out, there are some women they just can't accept, they just can't tolerate progesterone, even though earlier in their life they might have been pregnant and their progesterone levels were astronomically high. Doesn't seem to matter. There are reasons that those possible reasons for why those rare women don't tolerate progesterone. Sometimes those reasons can be unraveled, sometimes not. Progesterone for all women. Yes.
I had told my doctor that I was going to take progesterone. Oh my God, he jumped back like 4 feet and he was like, no. And I was like, really? And he's like, well, I don't know. I said, okay. And I did it anyway. On to number 3. And welcome, Brooke. It's good to see you here. We like Brooke. All right, here's a good one, and it might even be hers. I'm not sure. Maybe the next one is. Why is it, Dr. Rosensweet, that I am losing all of my hair, but I have really low testosterone? I thought this only happens when testosterone is too high, or DHT is present, or when taking DHEA, or all three.
Another great question. Hair,
I got great women.
Pardon?
I got great women.
Yes. Hair and the health of hair has many moving parts. And testosterone is only one of them. Like in a young woman who's just going through menarche, that means she's just starting to get her period. This is a time of a young woman's life where her hair could be the most abundant ever. And one of the principal movers and shakers of that one is the robust estrogen levels. And so, yes, these young testosterone plays a role in hair, but so does estrogen, big time. And when you see a woman have good hair for a long time, very often it's due to the estrogen. When testosterone is an issue, and it can be, and here's what I've seen: too much and too little. In a menopausal woman, a perimenopausal woman, here's the moral of the story: get hormone balance and amounts proper. Get them physiologic. Don't get them too little or too much. Hormones, again, are so powerful that too much hormone, big problem. Too little hormone, big problem. So sometimes, I mean, I suggest this for everybody, that you go to a living expert in this stuff, because these questions, one thing they unveil is, oh my God, there's a big knowledge base and a big experience base related to treating women with hormones. And this is a classic example. Too little or too much testosterone, problem. Just get testosterone right, which we can confirm by the proper hormone testing. And I'm going to say it out loud once again. The one that we know is 24-hour urine hormone testing. Every other method is suspect or incorrect or not as useful. Now, there's other players for hair, big ones, such as thyroid hormone. And thyroid hormone tends to decline over time, just like the rest of the hormones do, because pressure is put on that thyroid gland throughout our lifetime. If we are recruiting fight or flight biochemistry, thyroid is going to participate and help amp up the metabolism. Well, thyroid's very related to hair. So all of these things need to be checked. An intestinal tract that is compromised and is not absorbing the nutrients that hair is made out of. Hair is made out of protein and minerals. Yeah, that's easy for most adolescents to digest and absorb. They just suck it up. If they eat it, it goes in. Not so much for as people age. There can be significant digestive enzyme and hydrochloric acid diminished, both of which are required for protein and mineral digestion. There can be compromises to the gut, as you are using in your functional medicine training.
That is
you
true.
were learning. There can be compromises to the gut. It doesn't matter how impeccable the diet is. If you can't digest it, or you've got absorption issues related to leaky gut or some kind of inflammatory situation in the gut, all of these things need to be addressed. So 5 hormones plus, or at least estrogen, testosterone, and thyroid need to be considered. Plus what you're eating, you better be eating sufficient protein and minerals, which is an issue these days, because some diets are very protein lean for what that individual actually needs. And then your ability to digest and absorb whatever you stick in there.
Right.
All of those are most relevant to hair, and all of them need to be looked at.
Thank you. Okay. The hair
and
thing.
One more thing, Carolyn. If you've got too much DHT, or you really got a testosterone issue, you really got a dosage issue, usually an overdose issue. So not always, there are exceptions, but I just wanted to say this is the power of someone who knows what they're doing and has the tools to test and evaluate all of those moving parts that are related to something so significant as hair.
Right.
Don't leave any of them out.
Right. And so balance is so important.
Proper levels, proper balance, and all these other moving parts as it relates to hair.
Yeah. Yeah, it's a lot. And being in school, boy, I'm learning there's more than a lot to a lot to a lot to a lot. And welcome, Manon, I believe, and Donna, too. We'll get to your questions in a second. Glad you're here. This is kind of an interesting one, and I'm forgetting who asked it. Oh, I'm sorry. But anyway, it's a kind of a hard one. But anyway, I was diagnosed with LCIS, which I myself had DCIS, which stands for ductal carcinoma in situ. LCIS stands for L. I don't know what L.
Lobular carcinoma in situ? I don't know.
Yeah, L. I'm not sure. It could be. But anyway, it's in situ, and had to go off of all of my hormones. My doctor is now wanting me to take an estrogen blocker. Help! I've been going through peri for about 10 years now. HRT saved my life. I'm having hot flashes, mood swings, crying fits, and I'm already on antidepressants. So any like any advice would be appreciated.
Wow, Carolyn.
I know.
Super high quality questions.
I know.
You know, we're dealing with the biggest myth and misconception that has appeared in medicine in my lifetime. I've never seen any other field like neurology or gastroenterology or orthopedic surgery or any topic in medicine that you can name that receives such a misconception and myth as menopause, as treating women in menopause with hormones. And, you know, women have been treated for 1,000 years, and especially in the last 70 years with hormones, and have done really well. And then in 2002, and you've heard me talk about this, along comes this explosion. A very expensive medical study that was very poorly designed. Exploded this information that was false. Now hear this, false, that women who took hormones were at greater risk for breast cancer, heart attack, and stroke than women who were not treated. And you're going to hear me repeat it in different ways, that was the opposite of what is actually so. Even at the time of publication and ceasing of one arm of a two-arm study, because women were being treated with Premarin, horse urine-derived estrogens, that did a lot of good on this earth. Not the optimal thing, but back in its day, it was the best we had to offer early on. There was the Premarin arm, and then there was the Prem-Pro arm, and that was Premarin connected with another molecule called medroxyprogesterone acetate, a progestin, very problematic. But still, the Premarin arm always in that study illustrated that women who took Premarin were at less risk for breast cancer, heart attack, and stroke than women who didn't. And the Prem-Pro arm that stopped the study had a statistically insignificant number, relative risk associated with it. It was in the study. Many members of that study committee objected vociferously that the study be stopped because it was statistically insignificant, that increased risk. And in science and medicine, statistically insignificant is known as junk. It doesn't work. It's not worth anything. But politics, who understands these things? It exploded by the media. And 18 million women, 40% of the American women in menopause who were on hormonal treatment, it cascaded. They got terrified. Their physicians got terrified, and it fell way down into the low millions overnight. There was many extra problems associated with that loss, and it was all based on false information. And at that time, it scared me. My God, I had been treating women in menopause for 10 years, and I'm looking at this data come out. But I looked into the study, and my colleagues and I were discussing the study and went, "Oi, there's so many study design problems here. And look at that, it's statistically insignificant." And I went into the European literature around the bioidenticals, which was I was using, and it showed reduced risk. Well, I want to get down to the meat of this. By 2006, even that study committee knew that the 1.26 had reverted to 1, which means there was no increased risk. They knew that. And then finally, in 2017, the original study committee published in the original journal that after 18 years of follow-up, there was no increased risk of breast cancer, heart attack, and stroke. In other words, they retracted it. Now, as you know so well, and you were the one who introduced me to Dr. Avram Blooming, and oh my God, you knew him as a child, as a young, because your daddy and Dr. Blooming were friends. He's an oncologist in LA, and he and Carol Tavris have written this fantastic book on this called Estrogen Matters. And here's how I'd like to put it to you. That we are all at risk for diagnoses. Any medical doctor can tell you there's thousands of diagnoses, and a lot of them are not pretty. And in that not pretty, or that concerning category, is cancers. And we're all at risk for cancer. And men have an increased propensity risk for prostate cancer for reasons. And women have an increased risk for breast cancer for reasons. And I won't go into those reasons right now, but here's what every woman on this call and every woman on the planet Earth needs to hear. That women who are treated with hormones are at less risk for breast cancer than women who are not treated with hormones.
Can I interject something really quickly? Because I didn't have LCIS, I had DCIS, and so I wasn't allowed to have hormones for 17 years, as most people know. It was miserable. My life was miserable. I made the decision, risk benefit, to go on to hormones. And I'm saying this because this poor woman with LCIS, and now her doctor is wanting her to take estrogen blockers, and she's been going through peri, and she's on antidepressants and so on. They gave me antidepressants. They wouldn't give me hormones. I couldn't get out of bed. I couldn't move. I had vaginal, and I was a mess. And I made my decision for me, just for me, after meeting you, that I was going to go on to hormones. And I did. And 2 years into, all of my cancer numbers went down. So that's just for me. But anything under 38 was good. But I went from 11 to 9 on one and from 9 to 2 on the other, much to the dismay of my physician, who doesn't believe in hormone therapy at all.
It's a complex subject.
It is.
And how I like to look at it is that any illness has causes. And my favorite way to look at it is to say to a woman or anybody, any patient, that imagine that you had a video camera that recorded you from the moment you were conceived till now. And there was a magic editing button that was able to you push it, and it edits out all the good stuff. Like all the fun you had, all the good meals you had, all the exercise you were doing, all the love and happiness that you had, all the great living you had. It edits it out. What would remain is a story of your nutritional issues, your exercise issues, your ability to handle stress in a physiologic safe way, and your toxicity issues. And we'd see the story of how you developed whatever diagnosis that you have, including cancer. It's a complex picture. There's a lot of moving parts. And what I recommend to any woman who, and here's the other big issue, the medical community is still reeling from the 2002 misinformation. There's people out there beating the bushes, like Dr. Blooming and myself and many others, trying to counter that misinformation that came out, but it has not risen to public knowledge. Even the drug companies, who would benefit so much by removing their black box warnings, scaring women that they could get breast cancer, because it's inaccurate. It's scientifically wrong. It's the opposite of what's true. You know, the world has not caught up, which puts you, I'm sorry, I don't remember the name of who's asking this question, you and many women, and oh my God, you got to be in the driver's seat. Because 9 out of 10 physicians, or however many physicians that you go to, the information that they're working off of is going to be that you're at risk. And so they're not necessarily going to treat you. But there are physicians who have gotten deeply into this topic and are treating women in menopause who've had prior history of breast cancer. And so just know that. And oh my God, here you are, a human being and a patient. And you have to be the master of your own ship here, navigating through a medical world that throws up many obstacles. Don't let it dissuade you. Go for it. It really matters. And what I'd like to point out is that in general, that big scare was the opposite of what's true by their own admission. If you go to the 2017 Journal of the American Medical Association, that original study committee publishes that after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke for women on Premarin and Prempro. I'm not fan these days of prescribing Premarin or Prempro, even though a lot of good was done by Premarin and Prempro. I'm strictly a bioidentical compounded guy. Compounded bioidenticals, compounded bioidenticals. Oops, the record got stuck there.
Would that be compounded?
It was compounded. Yes, you did hear that. Compounded bioidenticals for a lot of reasons. But estrogen matters. You got to get it settled in your own guts to know what's right. And are we still at risk? Yeah. I'm so grateful I woke up this morning and I'm walking and talking and on, but I know there's no guarantees.
Right. And yes, the last thing you want to do is Google with your beverage of choice into the middle of the night and see it's now not the ICD-9, it's the ICD-11, you know, so there's 70 zillion, the Merck manual, whatever. We can talk ourselves into some pretty scary things. But with you at the helm, I think that we're kind of like in safe waters, and I'm extremely grateful. I have one more very short question. I see Elaine has a question, Desi and Donna again. So we're going to get to those in a second. Mike, this is a very simple question, so it won't take very much of an answer, I don't think. Famous last words, right? Are you for? Thank you for the answer to that last question too, by the way, because that's a heady question. I've been there and I get it, and it's scary. Estrogen block. Anyway, okay. Are you for women buying supplements on their own? A lot of women take a lot of supplements because they don't want to take hormones, so they take a lot of supplements. Anyway, buying supplements on their own, especially prior to taking hormones. Or do you feel that this should be under the guidance of a physician, supplements?
Oh, thank you so much for the short question that has
a
short answer.
It's a yes or no answer.
I'm going to try and give a short answer for this one. There's a lot of good information that people can acquire about nutritional supplements. And the challenge usually becomes in identifying which companies are producing the good supplements. And I spent many years of my career discovering that, there's the professional companies that are selling only the professionals. And then, oh my God, there's a wide variety of quality out there, from absolute garbage, like, for example, calcium carbonate. You need calcium, but hard to absorb and digest it. It's limestone. How well you can do with limestone? Or oyster shell. Or bones, ground up bones. This is tough for the human being to digest. Right. So yet you can educate yourself and you can read labels, and that can help you sort out the good from the bad and the ugly. And then there's professionals of all kinds, naturopaths, chiropractors, nutritionists, holistic medical doctors, on and on and on, that they really take this subject on, and you can bet that they are carrying and recommending the high quality supplements. You're going to spend money on supplements. It's better to spend a little more and go for the quality. That's as much as I'm going to answer that question, because there's a lot of questions out there. And I think one of our staff is managing the order of the questions, because I see there's a lot to sort through. So can we turn it over to?
We can. I just want to say thank you so much for answering my questions, my own, and then the ones that I was able to take from our page. And there are many more. Yeah. We'll do it again on Thursday.
Yes, we are doing it again on Thursday. And in the world of supplements, learn what you can learn. Go to the best store that you can. If you go to a health food store, for example, there's liable to be someone in that health food store. They care about supplements. They've sorted out the good companies. They know the good and the bad and the ugly. So you can at least start there, and look out for the fat-soluble supplements like vitamin D. You can overdose on vitamin D. You can overdose on vitamin A. They're so crucial. They're so important, but don't overdose on them, because they'll give you some challenge if you do.
Okay.
Onward, staff, are you going to flash some questions up, or Carolyn can just read them right off?
I see them. I can't scroll up and down, but I can go from bottom to top or top to bottom. I don't know if Andre's still there. Are you seeing the questions, Dr.
He hasn't. There they are. Here we come.
Okay, there you go. So
Question number one from Elaine. What is the effect of excessive nicotine use, like vaping, on hormones, particularly estrogen?
You.
I myself am not knowledgeable about the direct linkage, but nicotine use, vaping, I think of two things: the lungs. Oh my God. And I was a cigarette smoker in medical school, as were 3/4 of my class. And
Yikes.
I took a hit from smoking, so I know personally. I fortunately totally stopped smoking in my 30s, and but my goodness, not only the whatever you're inhaling is not okay for the lungs, which are delicate. For my God's sake, we think we got this endless reserve. We don't. We want to treat our lungs and everything with great gentle care, and don't inhale stuff that can injure them. And then nicotine itself, too strong a drug, too strong. It's going to interfere with a lot of stuff, but I don't know a specific effect on estrogen. Maybe somebody does. Next question.
Are you
Carolyn, you
getting
want
it?
to, here it comes. The next question's coming up. I mean, the better we can get off these stimulants and the more we can get off of them, stuff like nicotine, the better. So I'm going to, Carolyn, why don't you ask a question? Is the next question? Oh, here it is. And this is from Tabitha. My doctor has said he thinks I'm at the end of perimenopause, went 11 months with no period, and now 4 months of continuous bleeding, and it won't stop. I'm now on 40 milligrams of progesterone, but doctor won't give anything higher. How do we stop this? I'm at the end of my sanity. I can't keep bleeding, doctor says. Only way to get me to stop is hysterectomy. I am at the end of my sanity. Yeah, excessive bleeding is pretty common in women for a variety of reasons. And when it's occurring in the perimenopause and you haven't had an official period for a while, this needs to be examined by a good gynecologist, a gynecologist you trust. There's a basic workup that needs to be done, including a transvaginal ultrasound. And very often what that exposes is a uterine fibroid, a benign, totally benign tumor that's got hassle value. It's hassling, and it can trigger bleeding. But Tabitha, the best recommendation I can possibly give you is, if you have a gynecologist that you trust, go to that gynecologist and get the full workup that includes a transvaginal ultrasound to look at that uterus and look at that uterine lining. And perhaps you've done that. However, it's got to start there, because there's common causes of bleeding, like a fibroid or overdose of estrogens. These are the most common. I don't know if you're on estrogen, but overdose will certainly do it. But there's uncommon and less favorable, more risky, more dangerous, such as even some cancers will cause excessive bleeding, and they need to be found. And the great news is, when they're found, that if you catch them early, these treatments are absolute. A hysterectomy at that time, removal of the uterus, is almost in every case totally curable, cures that cancer. So I want to say it again. Please go to your gynecologist and get that basic workup. And maybe you have. Now, progesterone in high dosages sometimes will work to suppress that bleeding and even shrink a fibroid. But this is touch and go. This is iffy. And we want to begin with the gynecologist giving you the diagnosis to make sure that there's nothing that needs to be done in there, and that you can be patient. Bleeding can be very severe. It can be moderately severe. It can certainly be a hassle. But let's start with the gynecologist. And here we have a question from Lily. What is the hormone lacking severe PMS or illness from luteal phase? The hormone that can contribute to PMS, which has many symptoms, one of the symptoms that is so prevalent in PMS is overstimulation of the uterus. What overstimulates the uterus? What stimulates the uterus? In most cases, it's estrogen. And, you know, if you're in the perimenopause, you're at a time when estrogen is lower than it's been since you were 20, yet it can overstimulate the uterus if it's not balanced by this important hormone called progesterone. And the body, the female body, thinks a lot of progesterone. When a woman ovulates, for example, her progesterone levels skyrocket. They get to be 100 times the level of estrogen. Oh my God, 100 times?
That's a lot.
The female body must really like estrogens a lot.
Excuse
I'm
me,
sorry,
just
progesterone.
be right back.
Yeah, the female body loves progesterone, and you know it's very common that a woman can have anovulatory periods. That means she doesn't ovulate, and if she doesn't ovulate, her progesterone output is going to be minimal. There's ways to detect that just from symptoms. For example, if you have a clockwork regular period that's happening every 28 or 26 or 31 days, every clockwork, and then all of a sudden you have a period that's of a longer or time between or a shorter time between than your clockwork, you did not ovulate, or highly likely you did not ovulate. And that's a low progesterone period. And that's the time when you're most likely to get PMS, overstimulation of the uterus and breast glandular tissue, etc. There's another way that a luteal phase, because that's the second 2 weeks in a cycle. The first 2 weeks begins with the first day of menstruation. Another way that happens that's extremely common is progesterone output can decline earlier and more sharply, more deeply than estrogen in a woman who still ovulates. That means she's running into an imbalance. And one of the ways you can tell is if, let's say, you had period cramping and breast tenderness and issues when you started menstruating as a young woman in menarche, and then it went away, and you had many years of pretty low-key periods. Oh, there might have been some mild cramping. There might have been some mild symptoms. And then in your 30s, the severity returns. And you start getting PMS and uterine cramping again. What's going on there, even if you're having a regular period, what's going on there, your progesterone declined earlier and deeper than the estrogen output does of your ovary. Thus, you get into an imbalance. Instead of progesterone and estrogen being perfectly balanced, estrogen stimulates, progesterone quiets down that stimulation. They're unbalanced. The estrogen might have dropped, but the progesterone's dropped more in proportion, even though you're still ovulating. You need progesterone. And so when you talk about the luteal phase and you're having PMS that you haven't seen for many years, there's a progesterone depletion there. And my goodness, progesterone is so easy to obtain and so easy to administer. And so we alert young women in their 30s that if you're starting to get that imbalance, get thee to someone who can supply you with some progesterone, even over the counter. There's some good stuff, and start taking that progesterone to restore that balance, and see if you can't calm down that PMS on your own, or get professional help to calm down that PMS. It's the beginning of your progesterone journey that should last you a lifetime of augmenting it. And it's a jewel. And every woman should be on progesterone. As Carolyn asked the question, I suggested that very early on. Carolyn, why don't you ask one of your questions, and then I'll go back to the questions that are being flashed up.
Ask one of my questions?
Well, if you can see the question from Jill.
I can, absolutely. Well, first, there's a very kind compliment saying, I'm ready to move to Florida just so Dr. Rosensweet can be my doctor. And I'm serious. First doctor that cares and takes time to explain. He needs several awards. And I'm with you. I agree.
Let me address that for a moment, Carolyn.
Oh, okay.
You know about our team personally, and we've got a big team and a big mission. And one of the things that you can do is you become a member of the Menopause Method, and the healthcare provider, the physician or nurse practitioner, that we can link you up with in the state that you're in is they're in our residency program. That means in the beginning, they run every single consultation by me. I'm mentoring them. And then there comes a time where they get the basics down. Then they're running every single patient by me. So in a way that you get indirectly treated by me. And then that goes on for quite a period of time. So I'm involved in every single patient in the United States for those who are in our who are our members and are being treated by someone in our residency program. So
it's definitely behooved.
Contact us and we can tell you more about that.
For sure. So I have another question from Brooke, and hello, Darlene. Hi, honey. It says, why in your book, you say so yourself, if a lady gets leg pain or swelling, to stop taking progesterone?
Well, there's a lot of different ways to look at swelling in the leg. There's some women who had thrombophlebitis when they took the birth control pill. They had a blood clot in their leg veins. And that blood clot was usually from the oral estrogen in the birth control pill. Oral estrogen. This does not happen with topical estrogen. You are not increasing the propensity to coagulate or cause thrombophlebitis when you're using topical estrogen. And so the moral of that story for every woman on this call is estrogen is best taken and safest taken topically, applied to your skin or your mucous membranes, topical estrogen, because it doesn't do that. It doesn't force the inflammatory process towards inflammation. It doesn't force the coagulation mechanism towards hypercoagulation. It doesn't do that. Right. Whereas oral estrogen puts a woman at risk for thrombophlebitis and even pulmonary embolus. I've consulted with so many women over 25 years, and periodically I hear the story, when I was 18 or I was 25, I got a blood clot in my leg, and it went to a pulmonary embolus. But there is no concern there for reasons of estrogen if you're taking topical estrogen in the menopause. There is concern if you're taking oral estrogen. So we never recommend oral estrogen, except in...
I'm going to really quickly interject here that there's this amazing book, and it's called Happy, Healthy Hormones. And Dr. R does not miss a beat in that book. I have 3 copies, but I've printed them out. Underlined, highlighted. And if you guys, honestly, having Dr. R twice a week is so special. And that book is special. You'll learn a lot.
Let me continue answering this question.
So sorry.
Progesterone has diuretic qualities. Mm-hmm. That means you pee more water than usual when you have adequate progesterone. Or think of it opposite. If you don't have enough progesterone, you can get edema. So like anything in medicine, or so many things in medicine, there's a complexity to it. So one of the first things I'm going to think about when a woman is getting swelling is to increase her progesterone and the diuretic. Maybe she doesn't have enough. Let me keep going though. This, like anything, has got many moving parts, and it speaks to the bottom line for all of you women. This is a subject, I think your biggest job is to link up with a healthcare provider like that you would love and trust. It's not different than an auto mechanic. Any city I ever moved to, I take my time and I find the auto mechanic that knows what they're doing. Because or the dentist or anybody, you want to have your team. I'm not going to work on my own teeth. No, sir. I want to have a dentist who knows what they're doing. You want this for menopause. This is the moral of the story. Now, excessive estrogen will make women swell. Or if the balance between the amount of estrogen they're taking and the amount of progesterone they have is unbalanced, they don't have sufficient progesterone to balance, you can also wind up with swelling there. And, oddly enough, I have seen some women take progesterone and complained to me. I've had 2 patients, I can picture them. Haven't seen these women for quite a while, but both of them had thrombophlebitis when they went on the birth control pill. One of them was in her 70s when I was treating her. She had that thrombophlebitis when she was in her 20s, and the other one was in her 60s when I was treating her. And what we got, and both of these women complained of, God, my legs are aching, much like when I had thrombophlebitis.
Uh-oh.
And I said, okay, well, let's figure it out. Let's stop all hormones. And we did. Not that was a permanent strategy. And then let's restart them and see what makes the discomfort return. And, in one of those cases, it was the actual progesterone. So you never say never, but I listed 4 variables that can pertain to leg aches. Now, there's other things that can cause leg cramps, and it's insufficient magnesium, it's insufficient mitochondrial action in the muscles in your legs. That we put a high demand on our muscles. So it's like anything in the human body. There's a lot of possibilities, but of course, we want to start with the hormones and figure that one out. Is any of those hormones causing the leg aches or the swelling? And it's not hard to do it. You stop the hormones and see if the swelling goes away. Then you restart them. Now, I prefer to be the guiding physician in those cases where I'm actually doing it in a teamwork with the woman. And I'm going to pull a question that our team has been feeding up here. And this one's from Jill. Is it normal during titration for bleeding to occur? And if so, where would this fall on the too much, too little list of symptoms on estrogen and progesterone? Excellent question. The endometrial lining, providing there's no fibroid in there like I was talking about earlier, the endometrial lining is primarily under the stimulation of estrogen. So when a woman has not had a period for 6 months or a year, and she's being treated with hormones, number one suspect, excessive amount of treatment with estrogen. She's forming too thick an endometrial lining, and she doesn't have the progesterone balance, because progesterone, having sufficient progesterone to balance the estrogen actually also matters. But the most common thing I see in actual practice is the woman is on too much estrogen. Now, when you're dealing with someone who's really experienced and really skilled, they're going to be able to guide you into dosages that you start with. But sometimes someone who doesn't have the same level of skill and experience, they're not going to be necessarily suggesting proper dosages. And Jill is suggesting titration. I want to look at that word. What titration is, a woman has symptoms of hormonal insufficiency, let's say estrogen, she's getting hot flashes. And we start on a low dose of estrogen and we gradually increase, and the hot flashes start going away from that gradual increase. But if she goes too high, she's going to get symptoms of hormonal excess. That could be spotting or bleeding. It could be breast tenderness, overstimulation of estrogen. So she backs down. That's the process of titration. You start with low doses, you gradually increase with the intention of alleviating symptoms of insufficiency while falling shy or backing down from symptoms of hormonal excess. So again, sometimes that bleeding is just a matter of too much estrogen or not enough progesterone to balance it. And one of the safeguards we have there is someone who's really skilled at this. They're going to look at the dosage you're applying and your skin health, and they're going to go, oh my God, you went too high. The number's too high. Someone who doesn't know their strengths and the proper dosages may not pick that out right away. And bottom line, when you have excellent hormonal testing, such as the 24-hour urine hormone test, we have defined the parameters that are too much and too little. And sometimes when there's bleeding, we'll go there. But sometimes when bleeding comes on, there's a moment in time where a skilled health professional is going to say, gee, here you are spotting, and we're working with hormones. And you know what? Because I'm conservative, believe it or not, medically, I'm extremely conservative, just for reassurance that that spotting is not coming from anything other than a thicker endometrial lining. I want a transvaginal ultrasound, and I'll refer you to your local gynecologist or local transvaginal ultrasound giver, which can be in a hospital setting, outpatient. But but transvaginal ultrasound is a tool that I love, because what it'll spot is an abnormal endometrium. And it wasn't too much estrogen. It was that abnormal endometrium put out some spotting, abnormal endometrial cancer. When caught in an early stage, medically, a piece of cake to guarantee cure with a hysterectomy. Who wants to have a hysterectomy? Nobody. You know, how, if you can avoid it, of course. Who wants to have an operation? Who wants to have a tooth drilled? Nobody. But when it's the right thing to do, it's most excellent. So I rely very strongly on relationships with gynecologists and a woman's gynecologist, because I'll ask for a transvaginal ultrasound at the drop of the hat. And so many of them come back, and woman's gone into menopause. She hasn't had bleeding or period for a long period of time. She starts spotting. Usually it's from dosage issues, insufficient progesterone or excessive estrogen. But I am quick to get an endometrial transvaginal ultrasound and look at that endometrium. So there's no irregularity there. There's no excessive thickening. I want to see that. And once I can say to the woman, look, the spotting is caused by one of these imbalance things, because I just saw the transvaginal ultrasound report and you're cool. There is no suggestion of endometrial cancer. So in the menopause method, we're very conservative in that way. Bottom line, we don't want to discover trouble late. We want to discover it early. And most of the time in that bleeding, there isn't endometrial cancer. But I've been doing this long enough that I have run into endometrial cancer. And thank goodness we caught it early and the cure took place. And so technical moving parts here. This is where a good doctor really matters. Pardon?
Well, it's interesting in that women, God, in the 6 years that I've been doing my group, which is now our group, women have become so much more interested in the physiology and what's back of all of this, as opposed to just a standard, throw more and more and more on. And I think that that's really fascinating, and it's really good, as long as we learn and we learn together. I know that it's 2 minutes till 8, and there are a few questions that we didn't get to.
I'm willing to go an extra half hour, and I would like to take a diversion here for a moment.
Okay.
As much as I love technology and have done telemedicine exclusively for 10 years, and I was an early computer user. I bought a Macintosh when they first came on the market in 1984. I love it. I love the internet and the advantage of it. I avoided Facebook until our wonderful team said, David, you got to get on Facebook. And I've only been on it 2 months. And one of the first things I encountered on Facebook was something that alarmed me greatly. One thing I saw was a lot of women who were not getting their medical needs met. And they would come up with stories, and I've heard them all my career, that they tried to reach out and get the help, but the help they got was confusing and not necessarily friendly. And so women started turning to each other on the internet for answers. That's beautiful. I mean, here we are together, Menopause Method and Carolyn Shapiro's ins and outs of menopause merged because of the value. But the thing that concerned me is that a lot of advice that's coming on out there is not right. In fact, it's opposite, and it can lead people in the wrong direction. And, we're trying to make up for that. We really, this is what you wanted, Carolyn. You're totally committed to excellence. And so how do we link up? Because of that, because of your desire. And
Thank
so
you. And I
you
guess part
inspired
of
us all the way in. You inspired us all the way in to
thank you.
connect, linking up together. But I would like to say that this is, I said earlier, that your primary job as a woman is go shopping until you find the health professional that really knows their stuff around hormones and menopause, and you really trust. And sometimes that's a piece of work, but I'm highly encouraging you to do it. And, you know, you take your lumps. God, I've gone through many different attorneys, many different dentists, many different auto mechanics, and occasionally I took a lump from spending a bunch of money, and it didn't work out. But this is your primary job, because it's something like spotting. This is where I took off. Most of the time, the spotting is benign, but sometimes it isn't. But a good, experienced medical practitioner is going to say, okay, let's get the transvaginal ultrasound, and then we'll proceed. We want the safety of that knowledge first. So sorry to wax so off base, but again, your job, go shopping until you find one. There's a lot of good doctors out there. There's a lot of people who really care about it and is going to spend the time, and a lot of nurse practitioners, a lot of physician's assistants, a lot of compounding pharmacists who have links to doctors that they are doing good work, and you want to find them or immediately become a member of the menopause method. I'm not shy to say that we got this thing down as best as I've seen it, and because you want excellence here.
I gotta absolutely second that. I know 2 years in, and honestly, I gotta second that. I gotta. And if you're willing to go another half hour, I'm very excited. If I can really quickly interject just one question, again, there's so many. Please know, you guys, you can always write to me. I will ask the questions. Dr. R sees them. He'll answer them, and we'll go again on Thursday. No one's going anywhere. We are working hard at really trying to change this up for everybody, right, Dr. R? And make it, the specialty, like brain surgery or gastroenterology or, like right armology or whatever it is. It's the specialty. We women.
Do you know a good right armologist?
Me. Come see me. I'm pretty good at that.
All right,
but it's kind of unfair. And a woman wrote to me this morning from England, and she said, oh my God, she just became a member of the page, and she said, I'm being told to suck it up and just be strong. And you do know I jumped all over that one. And so I have a question about neurological symptoms, which I think you answered the other day, but so many women, she goes on to say, and this is always my favorite, so many women feel and think like they are going crazy because some of these symptoms can be debilitating. And boy, I know that, and I know that there are women that I'm seeing know that, and I know that you know that. We go over it and over it again, and I just want to say, that there is definitely help and hope. Definitely 100%. I am a different person than I was 2 years ago, for sure. December 21st, 2018. Never forget that date. Got the oils, put them on. That was that. So anyway, I don't know if you have other questions, but I do have some here.
I do. This is from Elaine, and yes, I answered number 4, and this is from Elaine. Have you heard of not so typical symptoms like extreme nervousness, internal tremors, and trembling on the outside? Can you talk about neurological symptoms due to an imbalance? So many women feel like and think that they're going crazy. Some of these symptoms can be debilitating. And there's 4 questions. They're excellent questions. let me start from the last question that was in Elaine's question. So many women feel and think that they're going crazy. I'm on this call with you today because 25 years ago, one of my patients in her mid-40s that I knew really well, and she was brilliant. She had retired in her mid-40s. Come on now. And before I even started my office day, she burst into my exam room, walked right up to my desk, and said, "I'm not going to try and illustrate exactly her emotional demeanor at the time." She said, "I'm going crazy," and she was really upset, and she really wanted to impress upon me that she was going crazy, and this was so different than the woman I knew. And it turned out serendipity or divine guidance. I'll go for divine guidance. I had been speaking with a world expert medical doctor on progesterone, and I knew that progesterone had calming effects, and I gave her some progesterone, and a week later, I get a call from her saying, "Oh my God, this is magical! I'm totally myself again. Thank you so much." These hormones are extremely powerful, and they all relate to well-being in one way or another. And when they're deficient, you can count on, for most women, having emotional and mental symptoms associated with them. And severe anxiety is one of them. Severe disturbance is another one. And going crazy, that's why I linked right up to that, Elaine, because that can be a symptom of not enough progesterone. Moral of the story: if you're perimenopausal and you're developing symptoms that are new and strange to you, before you draw any conclusions, march down right into menopause and become as much knowledgeable about it, and mainly find your right provider. That's your job. That's your main job. Now, I wrote a book for women, Happy Healthy Hormones, like Carolyn mentioned, and you can download it from the Ins and Outs of Menopause page, because I think the more you know about menopause, it can help you on your journey, because in the first year or so, it's up to you to become your own personal expert, and mostly to find an expert, and you can do it as a team. Going crazy is part of it. And then the neurological symptoms, and internal tremors and trembling on the outside and extreme nervousness. Well, you get this thin line between severe anxiety and this thing, these hot flashes that women have, for example, are extremely stressful, especially when they occur in the middle of the night. Many women, when they get a hot flash during the day or they break out in a major sweat, women are strong. This is not that big of a deal. But when they happen in the middle of the night and they wake you up from sleep, the part that really gives women the trouble is the adrenaline output. And, adrenaline has a lot of side effects, including feeling very anxious, very nervous, getting heart palpitations. There's women who've had constriction of the coronary arteries from this adrenaline hot flash in the middle of the night, adrenaline-induced hot flash. They wind up in the emergency room getting cardiac catheterizations because adrenaline is so powerful and can have some egregious side effects, including major nervousness. However, this is what we teach doctors and nurse practitioners. When a woman in a perimenopausal or menopausal age demographic comes to your office and she has a significant list of symptoms that she didn't have when she was younger, don't go doing these majorly fancy workups where you do a million tests.
Excuse me, just for a sec. Sorry.
Sure. You do a million tests, and no, treat the menopause and see what symptoms remain. And Elaine, that's where I'm going to go, is treat the menopause, treat it excellently, because that is required, and see what symptoms remain. Now, sometimes there's other issues involved. For example, some of this trembling and nervousness can have excessive thyroid output. I mean, there's thyroid conditions in which you get hyperthyroid and you can get some of this stuff, and that's not that uncommon. And sometimes, indeed, there are neurological issues. And there comes a point, well, here's how we handle it. We meet up with a woman for the first time in consultation. We've provided to her this extensive questionnaire. There's so many questions on it, but I've evolved it over 50 years of being a doctor. I get so much information, and I put all that information together. And if it looks like a primary menopause issue, we're going to just head down that hormonal balancing trail, hormone replenishing trail, and see if that doesn't alleviate the symptoms. But there's another option. As a medical doctor, I've spent my lifetime being assessing people who are not well. And if I get a hint that it's time to bring in the neurologist early on, we'll do that. So I don't want to just openly declare that treating the menopause symptoms with hormones and getting it right is going to be the cure to everything. Sometimes I'll hear symptoms that my intuition will say, let's do some additional work. Let's check that thyroid. Is there a hyperthyroid going on? Well, we can learn a lot just from a physical exam on that. Or are there neurological issues? And does this need to be put into the hands of holistic neurologists, who I really prefer, because there's a lot of things that can injure the brain. And one of the world's experts on this is Dale Bredesen, a medical doctor. And Dr. Bredesen defines the many, many things that can be injured to the brain. So even when there is neurological issues, we want to walk down that Bredesen protocol, for example, by a functional medicine physician or functional medicine professional of all kinds. So if this answer is blurry, just know that what you really need is someone who's got experience treating patients and can help make the discrimination between, yes, this is worth, let's just go down the hormonal replenishing. It could be adrenaline response. It's getting you so nervous. Oh, or the thyroid's being brought into this. And we want to assess that thyroid properly. Or someone who could make the distinction, especially when you're not responding well to excellent hormone treatment and assessment, when you bring in the neurologist or whatever specialist you need, because you're talking about tremors and issues like that. So it's medicine. And what's your need? Oh, how many people just would love to have to go shopping for someone who was excellent in hormones and excellent physician at the same time? Yeah, how many people love to do that?
It was not fun for me, I can promise you that.
But it's a search worth doing. And I can tell you one thing, our method is loaded with people who are devoted to becoming a specialist and an expert in treating women in menopause. And that's a good place to start to see if it's a hormone issue, or for one of our residents to say, you know what, we want to bring in a few other testing and consultations along the way. So Elaine, there's more input around those excellent questions. Carolyn, do you have
They're all excellent questions.
Yes, they are.
And they're all excellent answers, which is even better.
It is so interesting that
I had very quickly an experience with an emergency room doctor, a woman, and she complained to me. I was her patient. I'd known her, and I'd seen her many times, and she said, "Oh my God, this anxiety is driving me crazy." And guess what I said? Because you, Dr. Rosensweet. I explained to her why she was having that anxiety. And she has been able now to, thank you to you, help many of these women that come in thinking that they're having heart attacks, I'm not sure what she's doing for them, but she's able to explain. And I think just in the explanation alone as to why that is happening, those adrenaline surges, the cortisol rushes, whatever, when we understand and it's not open-ended, we don't feel like we're going so crazy. You know what I mean?
And you brought up another question. The moral of the story is find a good doctor or nurse practitioner. There's thousands and thousands of them. I myself, because of how I've lived my career, have met so many. I know that there's many who are challenging, and especially in this day and age when the profession has been so injured by so many different things. But it's good to have a good doctor. And sometimes that palpitation and that chest pain is not from hormones.
Correct.
I mean, half the women who die in the United States die from some complication of arterial sclerosis, and the coronary arteries are extremely vulnerable. So it all leads to the same thing. Get thee to a good doctor. And sometimes it's a good idea to go to an emergency room in the middle of the night.
Oh, you bet, because it could be a heart attack. But let me ask you this. Did you not dose your then 80-something-year-old mother-in-law who had 3 MIs?
I did.
Myocardial infarctions due to not taking hormones?
Yes, correctly. She had a hysterectomy in her early 30s, and she had 3. She had, over the course of time, gotten 3 coronary bypass surgeries. And yes, we treated her for other reasons. That's a whole other story. But what is important in this as well is that let's take a young man of the age of 40 and a young woman. This screen is backwards. And a young woman at the age of 40. They do not have the same relative risk for getting a heart attack. Young women have much less risk. In fact, you don't hear of a young woman keeling over on a tennis court and dying from a heart attack. But you do hear about that as some young men. And the difference, folks, is estrogen. And by the age of 60, let's see if I can do this with my hands together because it's a reverse image. By the age of 60, the incidence of coronary artery disease and heart attack equalizes in men and women. And what's the difference? Hormones, estrogen principally. So it speaks to really addressing perimenopause and menopause excellently right out of the gate. Or address it whenever you figure it out. If you're 80 years old, like Carolyn was suggesting, I treated my beloved mother-in-law and beloved mother in their late 80s to some advantage there. However, there's tricks to treating someone who hasn't had hormones for many years that you want to have an experienced practitioner. But the moral of the story is get to it as early as you can. Read our book, get a roadmap for what you're looking for, get on this trail of treating perimenopause as early as you possibly can, and menopause. And do it with someone who's really excellent at it. And if you want to get an idea of what excellence is, read our book. There's one description of excellence, and you want someone to rise to that mark and measure. And you want them to be doing 24-hour urine hormone tests. That's almost a giveaway that they put a lot of time and energy into the climbing that mountain of a test that's complex to understand, but it's so valuable. Just as a pointer, you could ask them, do you do the 24-hour urine hormone test? I'm not talking about other urine tests. I'm not talking about 5 points, 4 points, whatever it is, peeing on filter paper. And that's not what I'm talking about. I'm talking about 24-hour urine hormone test. Wow, we're going in many directions, Carolyn. Let's steer me back on course. If our staff, our team has another question, or Carolyn has another question, because yes, we've got 12 minutes remaining, but like Carolyn says, we'll be back on Facebook Live on Thursday, same time, same station.
Yeah, it's just amazing. I think it's amazing. We are developing a team of women who are learning so much, and it to me is really heartwarming. I know I've known a lot of these women quite a few years, and it's kind of heartbreaking in a way. Yeah, that we've been misled, but I think a paradigm shift is happening, and we don't have to be sent out at 50 to go sit and knit in the pasture, you know?
I have a question that was asked of me the other day that I'd like to respond to.
Please.
The question was from Carol. What are your thoughts on DHEA? I take 25 milligrams a day and feel good. Thinking of going to 50 to boost my test. No. Stop. Because number one, DHEA is important. My God, it's either a pro-hormone or a direct hormone, but whatever it is, its numbers are higher than any hormone, most hormones that we can name. the human body has some love of DHEA that's rather remarkable. And it's produced both by the ovary and the adrenal gland. And it can be a pro-hormone that gets converted to testosterone or estrogen, and it has effects all of its own. DHEA is extremely important, but it's like any hormone. You want to get it right. My mentor in DHEA 25 years ago said to me, no woman should ever be taking greater than 15 milligrams of DHEA a day. And when you're dealing with hormones and pro-hormones, too much does not work and is not okay. And it's unlikely to be safe over the long run. I wouldn't be that concerned about DHEA, but we do 24-hour urine hormone tests. I've got thousands of tests on women, both through my own practice and through those I mentor. And I can tell you, we can tell when a woman's on too much DHEA. I pick it out immediately. And I have yet to see someone that goes over 25 milligrams that's on what I would consider to be a sustainable level of DHEA that goes over 15 milligrams. And most women are coming in somewhere between 7.5 and 12.5 milligrams. But again, do not go over 15 milligrams, and certainly without testing. But I've never seen it be that someone's gone over 15 milligrams and they haven't gotten into excessive levels of DHEA. And this is a calamity waiting to happen because for some reason, 25 milligram and 50 milligram DHEA is readily available. And gosh, I was at a checkout counter at one of these standard pharmacies, and I saw a whole rack of 25 milligram DHEA available right at the checkout counter. And I went, this is a problem waiting to happen. And I'm concerned about what the motivation is allowing something like that. Because
I bought 50 milligrams.
And you can buy 50 milligrams as well. So again, Carol, I'm strongly recommending to you and all women, don't go over 15 milligrams. And if you want to be safe, all you're going to be safe on 5, most likely if you're in the perimenopausal age, and many of you will be safe on 10, but get tested. This can convert to estrogens and testosterone, and just get it right. It's like any hormone. It's like any strong thing. Get it right and don't take too much. And over 15 milligrams is too much.
Can I ask you something really quickly that just came up from Elizabeth, stating that her DHEA is high, but she doesn't supplement with it at all, and she doesn't have any idea why it's high. Does that get you to a good doctor and figure it out?
Yeah, that happens. One of the cases I explored was actually with a male, and we tracked it down to genetics. And in this case, it was Italian genetics. And we learned that some Italians have high DHEA. I'm not saying that's what your diagnosis is, but I never like to look at the DHEA alone. And my guess is it was a blood test called DHEAS that you got. And the state of the art in testing hormones is a 24-hour urine hormone test. And when we get that, we can test DHEA plus its principal metabolites, plus what DHEA can be converted to called testosterone and estradiol and estrogen. And so whenever there's one of these moving parts in this vast, amazing biochemical roadmap that can be revealed by excellent testing, both parent hormones and metabolites. So the next step from my perspective would be to get a 24-hour urine hormone test at the proper, if you're still cycling, we want to choose the proper time, and let's look at the whole picture. Because the amount of elevation, or whether the metabolites are elevated or why the DHEA elevated, I never draw conclusions until I'm looking at that 24-hour urine hormone test. Because it may be benign, as it was in this gentleman. It was a genetic quirk, and we eventually got reassurance from an endocrinologist that this was no problem. But it's worth investigating, and if you're cycling, you want a mid-luteal, that's 3rd week, if you got regular periods, for the 24-hour urine hormone test. And if you're not cycling, it won't matter. If you're in menopause, it won't matter. Get it anytime. I'd be a little surprised if you were in menopause and your DHEA was elevated. So I would want to investigate it. Rarely, and it happened once in my career, we picked up an adrenal tumor from an excessive hormone level. And it was a excessive cortisol level because it was a benign tumor, but they need to be operated on. And the anesthesiologist commented to the patient that he had never seen someone pick up a tumor that early. How did that happen? Because we picked it up on a 24-hour urine hormone test. It was a little bit too much. We did a CAT scan, saw the little bit of adrenal tumor. The small tumor was removed. Patient's fine. So I'm just mentioning that for completeness. I'm not saying that's what you have. I'd first want to see if there was a physiologic issue there. So it's, again, it takes me down to, as a doctor, is I want to do the usual doctor thing. I want to know a lot of information about you. It takes women an hour to fill out our questionnaire. It's a piece of work, but we learn so much. And that steers me towards proper testing if it's needed. And you keep going. You follow the bouncing ball. If someone's got something like an elevated DHEA, you keep following the bouncing ball that will lead you through the training we had as physicians. How do you work with someone who's not feeling well or has got an abnormal laboratory test? You follow the bouncing ball. You learn a lot about them through a medical history. You do appropriate testing, and you keep learning, you keep learning, keep learning until you see it. And it's pretty unusual that you don't see it. So we got time for one more question. What is it, Carolyn?
Well, geez Louise. I don't know. My other questions are over by my other computer.
Well, then let's call it a day, because we've gone 25 minutes longer than what we did.
We've gone over a lot of material. Yeah. And, one thing I do want to remind people of is that we have the webinars too. Those are really good. And I want to put those out if we can on.
That's Thursday night. The webinar is taking place, and it's at 8 o'clock Eastern time, 5 o'clock Pacific time.
So maybe we can put a link on the ins and outs of menopause with Dr.
That'd be
David.
great.
Yeah.
Andre will help you do that.
Yeah.
And it's an honor and a pleasure to always be doing this with you, Carolyn, and to all the women out there. It's great to see a lot of people chiming in there, and I say hello to you, and I wish you all so well. Let's get this one right, and then it'll last you your whole lifetime, which really matters. When you're 90 and you're on the floor with your great-great-great-grandchildren and you're playing, and you're able to get off the floor and walk to the kitchen, and you're laughing and you're thinking clearly, this subject of menopause is really worth getting right.
And you're teaching them yoga at 90.
Yeah, right.
That's the kicker. I can hardly get off the floor sometimes. No, I'm kidding. Now I can. Thank you, Dr. Rosensweet, so much for your valuable time, your wonderful time, for your wonderful answers. You're amazing, and you know that I think so for sure. And I'm looking forward to Thursday, indeed.
Yes, and, indeed.
For the women here, if we didn't get to your questions, write them to me. Dr. R will see them, or I'll see them, or whatever. We'll ask on Thursday, and we'll just do this all over again, and bells and whistles and everything. We're all going to feel better. Swear I know it. Right?
All right, everybody. Bye to you for now. See you next time.
Day. See ya.